Chapter 8, Renal and Metabolic Diseases of the Kidney. So we are going to talk about the diagnosis of certain renal diseases and metabolic diseases that have been aided by the performance of a routine urinalysis. Because the onset of some of these diseases can be asymptomatic, a urinalysis may often detect abnormalities before a patient exhibits any clinical manifestation. In addition, it can provide a means of monitoring disease progression and the effectiveness of any treatment. So we're going to talk about these clinical conditions for you as an entry-level CLS. Diseases of the kidney are often classified into 4 groups based on their morphological component that's initially affected. So either glomerular, tubular, interstitial, or vascular. Initially, renal disease may only affect one morphological component. However, when the disease progresses, other components are involved because they are closely related and close structural and functional independence is needed. Susceptibility to disease varies with each structural component. So glomerular diseases most often are immune-mediated, where tubular and interstitial diseases result from infectious or toxic substances. In contrast, vascular diseases cause a reduction in renal perfusion that subsequently induces both morphological and functional changes within the kidney. Now, of those 4, we have the glomerular, any kind of tubular problems. Interstitial is between and into the tissues, and vascular is any kind of damage happening to the perfusion or blood coming into the kidney. So on the left-hand side is a normal glomerular capillary. This is a cross-section version of the nephron from above. So when you're looking at the glomerulus in nephrotic syndrome, you can see that there is excess protein that's leaking out into the interstitial space. So what nephrotic syndrome is, it's a group of clinical features that occur simultaneously. They represent an increased permeability of the glomeruli to the passage of plasma proteins, most notably albumin. Nephrotic syndrome is characterized by heavy proteinuria. That means it's more than 3.5 grams per day. Additional features include hypoproteinemia, hyperlipidemia, meaning increased lipids. You also see these lipids coming out in the urine, and generalized edema. So there is swelling because of the loss of albumin. Plasma albumin levels are usually less than 3 grams per deciliter because the liver synthesis is unable to concentrate for the large amounts of protein being excreted in the urine. Hyperlipidemia in the nephrotic syndrome is caused by an increased plasma level of triglycerides, cholesterol, and phospholipids. Whereas the mechanism is still unknown, it is caused at least in part by the increased synthesis of these lipids in the liver and compounded by a decrease of their catabolism or breakdown. The loss of these podocytes on the outside, protecting the cell, you have increased permeability and the lipids can cross the filtration barrier and appear in the urine. They can appear as free-floating fat globules found in the epithelial cells. The generalized edema with nephrotic syndrome is characterized by soft pitting, a depressed or indentation of the skin, and probably due to a decreased excretion of sodium. Edema is usually apparent around the eyes and the legs, but in severe cases, patients also develop effusions or excess buildup of fluid in the lungs or stomach. Along with heavy protein urea and lipid urea in these patients, urine microscopic examination often show a mild microscopic hematuria, meaning small amount of blood coming out in the urine. In addition, pathological casts such as fatty, waxy, and renal tubular casts are often present. Syndrome occurs in patients with minimal change disease, membranous glomerulonephritis, focal segmental glomerulosclerosis, and membrane proliferative glomerulonephritis. Glomerular and nephrotic types of diseases can be primary or secondary in nature. Primary meaning it specifically affects the kidneys, and it's often the only organ involved. They are primary diseases consisting of several different types of inflammation to the glomerulus. So when we talk about nephrotic syndrome, they have the categories of minimal change disease, which is a characteristic of the glomeruli that look normal by light microscopy. However, during electron microscopy, it reveals a minimal change or a loss of those podocytes or foot processes of the cell. They're the most often cause of children's diseases due to some kind of dysfunction of T cell immunity, can be thought of after infection or immunization, but they do recover very well. Membranous glomerulonephropathy accounts for 30% of all the nephrotic syndromes in adults. It is thought to be caused by IgG and complement depositing and thickening the basement membrane that leads to a loss of foot processes. The last, focal segmental sclerosis, occurs where some points and some parts of the glomeruli are causing it to be damaged or sclerosed. Logically, they show lipid deposition, collapsed basement membranes, and proliferation of the mesangium or the lining. This leads to a cause of loss of foot processes and thickening of the basement membrane to be caused by AIDS or heroin or drug use. Secondary diseases that causes glomerular damage are known as systemic lupus, which is an autoimmune disorder with immune complexes depositing and complement activation, leading to the loss of foot processes and the causes of protein spilling out. Diabetes mellitus is a carbohydrate metabolism disorder that leads to the glomerulus syndrome, hypertension, or other kinds of susceptibility to infection. Amyloidosis is a systemic disease involving many organs, though it's characterized by depositing amyloid, which is a pathological protein which leads to nephrotic syndrome due to the thickening of the basement membrane and loss of foot processes. So as a review, the nephrotic types of syndromes are a group of clinical features that occur together that lead to heavy proteinuria. So that's going to come up on your dipstick as heavy or 3+. Hypoproteinemia, because all the protein is leaking out into the urine, there's not a lot in the plasma or serum. You're going to have hyperlipidemia, meaning an increased amount of lipids in your blood that also lead to a lipiduria, meaning lipids coming out into the urine sample. Patients will exhibit edema, meaning that there is excess fluid around their eyes, usually, or around their extremities like hands and feet. So in the microscope, you're going to see a little bit of red cells, but you're going to see that fat coming through either in a fatty or waxy cast, as well as tubular epithelial cells. You also might see a foam, a white stable foam on top of the urine for the physical characteristics, telling us that albumin might be present. Now, nephritic syndromes are a group of conditions that induce inflammation of the glomeruli or kidney. It is often caused by immune response triggered by an infection or another type of disease, leading to an antigen-antibody reaction, which causes a loss of these endothelial cells within the glomerulus. Now, this leads to all of your red cells spilling out, so you have an increased red cell loss. And because it's an infection, you have a lot of white cells coming to the area too, which are also coming out in the urine. You might see a decrease in urine output or oliguria because inflammatory infiltrates reduce the fluid movement across the membrane. And in turn, this leads to increased blood pressure or hypertension due to the inflammation. You may have a little bit of protein coming out in your urine, and you may see granular cast due to the breakdown of the red and white cells. Let's talk about some of the categories or classifications of diseases within the nephritic syndrome. So we're going to start with acute glomerulonephritis, and this is an acute or quick type of infection caused by a streptococcal infection, usually 1 to 2 weeks after the throat or skin has come in contact with this bacteria. Although this disease appears most often in children, it can affect individuals of any age. Only certain strains of group A beta hemolytic streptococci induce these kinds of nephritis. The time delay between this infection and the clinical presentation usually correlates with the time required for antibody production. And what happens here is the accumulation of these antibodies destroy the endothelial line and causes damage in a crescent type of form that occludes the tubules, which also decreases the urine output. And over time, if this progresses, a patient can then develop an edema. But again, this is weeks after infection, and if it doesn't get resolved. Rapid progressive glomerulonephritis is also termed crescent glomerulonephritis because it's characterized by cellular proliferation in the Bowman space to form crescents from which the initial name derived. These crescents within the top cause pressure changes and can occlude the entrance of the proximal tubule. Infiltration of white cells with fibrin deposition within these crescents are also very characteristic of this type. And as a result, there's degenerative glomerular damage characteristic by wrinkling and disruption of the basement membrane. Now, this can develop after an infection as a result of a systemic disease or unknown due to some kind of flu-like symptom. 80% of patients with rapid progressive glomerulonephritis eventually develop into a chronic glomerulonephritis and require long-term renal dialysis or kidney transplantation and can cause death. Membranous glomerulonephritis is the deposition of immunoglobulins and complements along the epithelial mesangium, which leads to cellular proliferation along with leukocyte infiltration and thickening of the glomerular basement membrane. As a result of the increased numbers of mesangial cells, they take on the appearance of a lobe. Most cases of membrane proliferative glomerulonephritis are immune mediated, and these immune complexes in the glomeruli deposit following activation due to some kind of infection. This is a slow progressive disease with 50% of the patients developing chronic renal failure. IgA nephropathy is a deposition of IgA in the glomerular mesangium characteristic by one of the most prevalent types in the world. This can develop 1 to 2 days after a mucosal infection of the respiratory, GI, or urinary tract from infectious agents like bacteria or viruses that stimulate IgA synthesis. And as a result, serum IgA levels are frequently elevated, which lead to these immune complexes present in these patients, causing initial damage. Okay, so let's review for nephritic syndrome. Now, this is a group of disorders that present with a mild type of proteinuria on the dipstick. You have blood in your urine leading to 2 to 3 plus on your chemical dipstick, which could also show you a bloody physical characteristic. With a little bit of cloudiness due to the increased leukocytes that are present, leading to a 1 to 3 plus leukocyte esterase dipstick. In the microscope, you're going to see red cells, white cells, possibly bacteria, not all the time. You might see granular cast due to the breakdown of the white cells and red cells, and you might see renal tubular epithelial cells. Now let's move on to conditions or renal diseases that are caused due to tubular type of diseases. This is either grouped into acute tubular necrosis or some kind of tubular dysfunction. Acute tubular necrosis is characterized by the destruction of renal tubular epithelial cells. The causes are usually due to 2 distinct types, either ischemic or toxic. Ischemic follows a hypotensive event or shock due to a decrease in blood pressure that results in decreased perfusion or a decreased blood input of the kidneys, followed by tissue ischemia, meaning if the tissues don't get oxygenated because of the lack of blood, they will start to die. So in contrast, toxic acute tubular necrosis results from the exposure to any kind of nephrotoxic agent that has been either ingested, injected, absorbed, or inhaled. The tubular damage that results from either type of ATN can be reversed once the initiating agent has been identified and addressed. The causes of ischemic ATN are sepsis, shock, and trauma. However, any obstruction to renal blood flow or occlusion can result in the hypoperfusion in renal tissues and ischemia. Examples of sepsis and shock include extensive bacterial infections or severe burns. An example of trauma include crush injuries and numerous surgical procedures. Variety of causes to toxic ATN, and they're divided into 2 types of groups. Now, these dangerous toxin can cause oliguria and acute renal failure. Due to the damage of the renal tubules, you might see the sloughing off of renal tubule cells and sheets, in addition to renal tubular casts or granular casts of that nature, depending on how long the infection has lasted. Renal tubular acidosis is characterized by the inability of the tubules to secrete adequate hydrogen ions despite a normal filtration rate from the glomerulus. Consequently, despite these patients being in acidosis, they're unable to produce an acid urine. The renal tubular acidosis can be inherited, or it can be secondary to a variety of diseases. They are classified into 4 different categories based on their renal tubular defect. In type 1, the dysfunction appears to be twofold: an inability to maintain normal hydrogen ion and an inability to increase tubular ammonia to compensate. Type 2 is characterized by a decreased proximal tubular reabsorption of bicarbonate, and as a result, an increased amount of bicarbonate remains in the distal tubular reabsorption. Type 3 expresses characteristics of type 1 and 2. And type 4 is characterized by an impaired ability to exchange sodium for potassium and hydrogen in the distal tubules. Now we're talking about tubulointerstitial disease and urinary tract infections. Because of their close structural and functional relationships, a disease process affecting the renal interstitium inevitably involves the tubules, leading to tubular interstitial disease. Numerous conditions are capable of causing this process. And lower urinary tract infections can be involved because it represents a mechanism leading to the development of acute pyelonephritis. Urinary tract infections can involve the upper or lower urinary tract. A lower UTI can involve the urethra, the bladder, or both, whereas an upper UTI can involve the renal pelvis alone, or can include the interstitium, called pyelonephritis. They are very common in females, 10 times more than males. The disposition in females is due to several factors, such as short urethra and that's close proximity to the vagina and the rectum. Hormones can also enhance this bacterial adherence, causing a milky type of bacteria leading up through the urethra. To distinguish between upper and lower urinary tract infections, we have to take into consideration certain types of symptoms. So lower urinary tract infections are characterized by pain or burning upon urination, and the frequent urge to urinate even when the bladder has just been emptied. Other symptoms will include, or may not be present, low-grade fever and pressure or cramping on the lower abdomen. Very important to note that a common sign in elderly is confusion and distress. Now with routine urinalysis, you can see leukocyturia and bacteria in the absence of pathological casts. This differentiates a lower UTI from an upper urinary tract when they're present. Now, acute pyelonephritis is a bacterial infection that involves the renal tubules, interstitium, and renal pelvis. The two mechanisms lead to a kidney infection: movement of bacteria from the lower tract to the kidneys, and localization of bacteria from the bloodstream in the kidneys. The most common cause is ascending urinary tract infection from gram-negative organisms that are normally intestinal flora. If the bacteria reach the bladder, they are prevented from ascending to the urethra to the kidneys by continuously flow of urine. However, when the bladder is emptying or incomplete, a few bacteria can proliferate and reside in the residual of the bladder. Now, acute pyelonephritis is associated with bacteria moving up to the kidneys, caused by the influx of the vesicle up towards the kidneys. Now here you will see leukocytes as well as other types of casts, such as leukocyte casts, granular renal epithelial cell, and broad casts, as well as bacteria. Another clinical factor is acute pyelonephritis has a sudden onset characteristic by flank or side pain due to dysuria and the frequent urge to urinate. Now, chronic pyelonephritis develops when there's persistent inflammation of the renal tissues, causing permanent scarring that involves the calyces in the pelvis. Many diseases can cause this, but most do not involve the calyces in the pelvis. Acute interstitial nephritis is any immune response into the interstitium of the kidney can cause this. Various drugs and other conditions can be involved, but the most common is an acute allograft rejection of a transplanted kidney. So other types of medications such as antibiotics, methicillins, cephalosporins are most notably caused by this. The resulting factors for acute interstitial nephritis are hematuria, mild proteinuria, and you might see leukocytes with or without bacteria. A differential analysis of the urine's white cells will reveal an increased number of eosinophils. Instead of those neutrophils that kill bacteria, here you have some kind of reaction to the medication or another type of substance here. Now, the last thing is yeast infections. The urinary tracts of men and women are susceptible to yeast infections and most commonly occur in the vagina. Candida are normally flora in the GI tract, and their proliferation is kept at check by normal bacterial flora. When the flora is disrupted by antibiotic and pH changes, yeast can proliferate, as well as blood catheters. So if you see yeast, this could be a common cause. Now we're talking about vascular diseases. Because the kidney function is directly dependent on receiving 25% of cardiac output, any disruption to this blood supply will affect renal function. So first, let's talk about acute renal failure, which is characterized by a sudden decrease in the glomerular filtration rate, increased azotemia, that's a breakdown products in your blood of ammonia, and oliguria, which is a decrease in urine output. The nephrons look functionally abnormal. No abnormalities are seen. Now, the classifications here can be deemed, depending on their location, as pre-renal, renal, or post-renal. Approximately 25% of cases are pre-renal and result from a decrease in renal blood flow. Any event that reduces the arterial pressure causes a reduction in the flow rate in the kidney. So therefore, acute tubular necrosis is the most common cause of acute renal failure. Other conditions that cause a sudden reduction in volume are associated with this type include hemorrhages, burns, surgical procedures, and a lot of diarrhea and vomiting. Now, renal causes of acute renal failure, approximately 65% of the cases, characterized by renal damage and results from any glomerular, tubular, or vascular disease process. Most patients present with acute tubular necrosis, and it progresses to renal tubular destruction that leads to loss of water and electrolytes. This injury can lead to a chronic type of condition if not resolved. Post-renal causes include obstructions in urine flow and account for about 10% of these cases. Mechanical obstructions within the kidney can result from various sources such as drugs, amino acids, solutes, and certain types of cancers. Now, chronic renal failure is a progressive loss caused by an irreversible and intrinsic renal disease characterized by chronic renal failure. Here, the glomerular filtration rate is slowed down but continues to decrease and becomes clinically recognizable only after 80 to 85% of the function is lost. The course is described as very slow and silent. Early in the course, the remaining healthy nephrons hypertrophy to compensate for those that are destroyed. Numerous diseases cause chronic renal failure, with the glomerulonephritis accounting for 50 to 60% of these cases. Diabetic nephropathy is the most common cause of chronic renal failure. When we talk about end-stage renal disease, you will start to see a fixed specific gravity called isothenonuria at 1.010, significant proteinuria, minimal to moderate hematuria, and the presence of all types of casts, particularly waxy or broad. So this is the end stage of life. Now, calculi or renal stones are another subset of problems that can have detrimental effects in the kidney. Calculi are aggregates of solid chemicals interlaid with a matrix of protein and fat. They form within the body and can be found in any secreting gland, including the pancreas, gallbladder, salivary gland, and urinary tract. Less than 1% of the population develop these stones, and 75% include calcium as a main constituent. Now, the factors that are influencing the formation of calculi are supersaturation of chemical salts in the urine, optimal urinary pH, urinary stasis, meaning no movement, or nucleation or initial crystal formation. For the amino acid types of disorders, we're just going to talk about and focus on cystinuria. Cystinuria is a disorder classified or characterized by excretion of large amounts of cysteine in the dibasic amino acid arginine and lysine. It's an inherited autosomal recessive disorder in which the nephrons, for example, the proximal tubule cells, are unable to reabsorb these amino acids. These patients have defective intestinal absorption of the same amino acid. Now, because of its low solubility, in vivo cysteine precipitation and calculus formation can occur. Clinical symptoms will include hematuria, because of these crystals and their sharp edges can cause bleeding in the urine, and severe and abdominal lower back pain. Now, treatment for these patients to prevent crystallization from forming in stones, they have to stay well hydrated, particularly at night when urine becomes more concentrated. They can also take oral administration of D-penicillinamide. We're going to wrap up with talking about carbohydrate disorders. Our first one is diabetes mellitus, which is not a single disorder, but a group of disorders that affect the metabolism of carbohydrate, fat, and protein. It is characterized by chronic increase of sugar in the blood and glucose coming out into the urine, both which provide evidence of impaired ability to utilize glucose. Diabetes mellitus develops when defects are in insulin production, insulin action, or both. Now, they're classified into two different categories, type 1 or type 2. Type 1 diabetes was previously called insulin-dependent diabetes mellitus or juvenile onset diabetes, and accounts for about 5 to 10% of all diagnosed cases. Type 1 can occur at any age, however, most individual symptoms happen before the age of 40 years old. Type 1 diabetes develops when the immune system destroys the beta cells responsible for the production of insulin and often presents suddenly with an acute illness with ketoacidosis. Other classic symptoms include frequent urination, ketonuria, and rapid weight loss. These individuals require insulin injection or an insulin pump to maintain normal glucose levels. Type 2 diabetes was previously called non-insulin dependent diabetes mellitus or adult onset diabetes. It usually presents after the age of 40 and accounts for 90 to 95% of all diagnosed cases. Although obesity is common and often associated with type 2 diabetes, it is not found in all patients with type 2 diabetes. It progresses very slowly and is often initially detected during a routine wellness screening or during testing for other clinical concerns. In the early stages, the tissues are insulin resistant, unable to use insulin properly, and with time, the pancreas gradually loses its ability to produce insulin to overcome the resistance, and then hyperglycemia develops. Many patients with type 2 diabetes mellitus require insulin and are able to control their blood glucose by following a certain kind of diet, increasing physical activity, and taking certain kinds of oral medications. If left untreated or unmanaged type 2 diabetes can lead to an end-stage renal disease, or most commonly called is diabetic nephropathy, as it increases the risk for cardiac, cerebral, and peripheral vascular types of diseases. We will finish up with diabetes insipidus, which got its word diabetilin, which means to pass through or siphon. It just refers to the copious amounts of urine that this disorder produces. The term insipidus refers to the bland state of urine produced. In contrast, the term MELLITUS means sweet and is used to describe the disorder characterized by polyuria with glucose, like we talked about in diabetes mellitus. So diabetes insipidus can be separated in two types based on the defect responsible. Is it neurogenic or is it nephrogenic? So in health, antidiuretic hormone, also known as vasopressin, is synthesized in the hypothalamus but stored and released in the posterior pituitary. Neurogenic DI occurs when the release and synthesis of ADH are reduced. In contrast, nephrogenic DI presents with normal synthesis and release of ADH, but a defective tubular renal absorption or response to ADH. With both types, water is not reabsorbed by the renal tubules, regardless of what the body needs. This causes polyuria and polydipsia. So DI can be induced by convulsive water drinking or by the use of certain types of drugs. So the copious amounts of urine produced appear to dilute the patient's urine to produce a low specific gravity, unlike that of diabetes mellitus. Diabetes insipidus patients are unable to produce a concentrated urine even when fluids are restricted. Note that dehydration can be life-threatening because the plasma can become hypertonic and patients can go into shock. As long as patients with DI are able to reduce or replace the large of water being excreted by the body, they can maintain a healthy and normal plasma osmolality.